Hello, welcome to your own personal study guide to help you prepare for CSE. I appreciate you, Sloan, and trusting your review efforts to our page. So the first thing that we're going to talk about is hemodynamics, just to make sure that you are familiar with exactly what you're going to need to know for the exam. We want to make sure that you understand that when they give you a patient that has fluid overload, that you're going to see an increased CVP, PAP, PCWP, cardiac output. So in order to be able to recognize those, you need to know the normals. So make sure that you have concreted in your memory knowledge base that normal CVP, which is 2 to 6 millimeters of mercury, is the average. Make sure you understand that PAP normal is 13 to 15 millimeters of mercury. Pulmonary capillary wedge pressure is 7 to 9 millimeters of mercury, and normal cardiac output is 4 to 8 liters per minute. So you want to have concreted that anytime that there's an increase in the pressures in the heart, that there's likely fluid output. So there's some type of heart failure going on. And so you want to recognize when they give you a patient on the CSE that has not just these numbers, but also has pitting edema, pedal edema, increased jugular distension, has inflammation or swelling in their face, hands, it can be in their legs, in their stomach, in their arms. You may see extra fluid around their eyes. So anytime that you see this fluid retention, you know that you want to recommend that a diuretic is initiated as soon as possible. So our most common diuretic would be furosemide, which the trade name is Lasix. And then a less effective diuretic that I'm not really a fan of because it just doesn't seem to do the same job that furosemide can do is Bumex. And not only do we want to stimulate the kidneys to flush out the fluid overload, we also want to increase the cardiac output by increasing contractility of the heart using digitalis or digoxin in order to improve the pump action of the heart. So it's very important to do that. That way we reduce that extra distress placed on the patient. So you know that CVP is central venous pressure. Normal is 2 to 6, as we discussed, or 4 to 12 centimeters of water. And it's taken at the right atrium in the vena cava as the blood returns to the heart from the periphery. So when it's high, it's usually related to fluid overload. We need to diurese the patient. When it's low, it could be dehydration or vasodilation. So we want to get an IV in as soon as possible and increase the fluid and maybe give some vasoconstricting medication. So this the CVP relates to the right heart function. It's the pressure in that right atrium or in the vena cava. So keep separated what pressures affect what side of the heart. And then you want to make sure that your pulmonary artery pressure, the normal is 25/8 with a mean of 14. Normal range is 13 to 15. And we place that catheter transducer in the pulmonary artery to monitor that. So this is also called right ventricular afterload. It's commonly high in COPD patients, and it's the best place to get a mixed venous sample because the blood is adequately mixed in that area. So the pulmonary capillary wedge pressure is a very important measurement that we see a lot on board exams. The range is 7 to 9 millimeters of mercury with a normal of 8. And this measurement is taken with the balloon-tipped catheter inflated and wedged in the pulmonary artery. Now, you're going to see different names for that catheter. Swan-Ganz catheter, it may be referred to as that. So this pulmonary capillary wedge pressure can be referred to as pulmonary venous drainage, left atrial pressure, left ventricular filling pressure, left preload, or left ventricular end diastolic preload. And it's also it's the diastolic portion of the pulmonary artery pressure can be used to estimate what the pulmonary capillary wedge pressure is going to be, because there's a very small difference in the two, just 0 to 4 millimeters of mercury. So you want to be able to keep an eye on that, and that's going to tell us what's going on the left side of the heart. Cardiac output is also expressed as a volume rather than a pressure. Normal is 4 to 8 liters per minute. It may also be expressed indirectly as the cardiac index. So the cardiac index is the cardiac output divided by the body surface area. And the body surface area is about 2 meters squared. So cardiac index is about half of cardiac output, unless another BSA is provided that is different than the 2 meters squared. So just watch that if you're asked to calculate it. So it may be calculated using the Fick equation. It's most often measured by a computer through thermal dilution. So you may have seen that question on your TMC, but it also may be calculated by simply multiplying stroke volume by heart rate. And it generally relates to the condition of the left ventricle. And we know that that's very important, because that left ventricle is what pumps out blood to the oxygenated blood to the periphery via the aorta. So that needs to be a good, strong, not only amount, but it needs to be well oxygenated blood as well, so we can accomplish that perfusion at the tissue. So all of these are super important in monitoring the efficiency of the heart, and you need to know the pathologies that occur if the heart is functioning inefficiently, and you need to know the difference in what's causing the problem. If it's not, is it causing pulmonary edema in the pulmonary system? Is fluid seeping back into the alveoli because the heart's not pumping sufficiently, or and causing a fluid overload? Or is it like an ARDS situation? So we have the non-cardiogenic, not heart-related pulmonary edema, like we see in ARDS, because there's been a trauma or some type of exposure that's caused the ARDS, or a chronic infection that's not been corrected, like a severe pneumonia. There's a lot of different things that can cause ARDS, but remember that that's referred to as non-cardiogenic. It's not caused by the heart, but it's caused by that loss of compliance. And then there's also going to be a loss of perfusion, so you're going to have that refractory hypoxemia associated with ARDS. And then there is cardiogenic pulmonary edema, which is going to cause fluid overload, and then that's going to seep across the AC membrane from the bloodstream, and it's going to seep into the alveoli, which is going to create also an oxygenation issue. So then we would use our positive pressure and hopefully a diuretic and maybe something to help contractility, and through all those, the positive pressure pushing the extra fluid out, and then the kidneys being stimulated by the diuretic, hopefully we'll be able to clear that extra fluid and correct the fluid overload. So know how to recognize and treat both cardiogenic and non-cardiogenic fluid overload. Also be able to recognize dehydration, like decreased skin turgor, when you have the ability to pinch the skin, and then it doesn't go back quickly into its normal resting position. If it stays up when you pinch it, the patient's dehydrated. If you have flat jugular veins, when instead of having distended jugular veins that we see in fluid overload, if they're flat and sunken, then you're going to have dehydration. If there's color and a lot of dark urine is typically clear, or as close to clear as possible, reflects the optimal hydration. So if you have super dark urine, then you know that patient is dehydrated. And then you can look at some other blood work and see dehydration as well, that we'll talk about in a bit. So you want to know what your hemodynamic normals are. Are they too high? That's fluid overload and a type of heart failure, or ARDS. And if they are too low, then you know the patient's dehydrated and you need to suggest fluids by IV as soon as possible. So we need to also be familiar with systemic vascular resistance, and that normal is 1440 dynes, and then pulmonary vascular resistance is normal 160 to 200 dynes. So systemic range would be 1400 to 1600 dynes. That's a lot higher. And then your pulmonary vascular resistance range is 160 to 200. So make sure you're familiar with those in case you're asked on the exam. Be able to recognize when that they're normal and when it's abnormal. Also, on the CSE, you're going to be asked a lot of questions about mechanical ventilation. So being able to recognize what is the problem related to? Practically every scenario is going to be related to one or more of the critical life functions, with ventilation being priority, oxygenation being second, yet a close priority, circulation being third, and perfusion being the least important, but certainly very important, as we've got to have tissues and organs perfused with fresh oxygen in order to be able to sustain life. So all four are critical. Note that ventilation is a priority. So how do we recognize ventilation issues using the ABG? We know that ventilation is reflected by the PCO2, and then if the PCO2 is high, our pH is going to be acidic or low, and then if the PCO2 is low, the patient's hyperventilating and the pH is going to be higher. So we need that pH to be right at 7.40 in order to reflect homeostasis. Make sure that you know your normal blood gas values. If it's outside the range of 35 to 45 for the PCO2, then you know there's a ventilation problem. If it's outside the range for PO2, then you know that there's an oxygenation problem, as well as saturation. If that's low, you know that you need to treat that oxygenation problem, most commonly with FiO2 and PEEP. So knowing what the normals are is super important. Knowing if your bicarb needs a boost, then you need to do that by administering bicarbonate. And then recognizing whether it is a chronic or an acute problem. Is the pH balanced but the PCO2 is still high, then you would know that that's a chronic obstructive issue. So watch your pH values and know if is this the patient's baseline. Is it emergency? So know your key words like marked. If it's marked, then you know that it's emergent and it needs to be corrected as soon as possible. So you need to know your base settings for mechanical ventilation. to decide if you need to intubate or if you can place the patient on NPPV, non-invasive positive pressure ventilation, to help correct that ABG first. So if your pH is still higher, maybe it's higher than 7.26 or more, then you may be able to intervene with NPPV and combat having to intubate the patient and place them on mechanical ventilation. But if it's less than 7.25 and the PCO2 is rising because of a respiratory issue, then you're going to need to go ahead and intubate the patient. If the patient is unconscious or comatose, that's a direct key word that says go ahead and intubate because they're unable to maintain their airway. If they can't follow commands or instructions, they're confused or disoriented, if they're obtunded, if they have any type of aspiration or any type of head or neck trauma, maybe they've been involved in a motor vehicle accident and come into the emergency room, then you know that you're going to want to stabilize that airway by going ahead and intubating. You can choose non-invasive if they've not completely went into ventilatory failure. If they just have a rising PCO2 that you feel like you can correct by increasing ventilation. And if they are still able to cough and clear and expectorate, and they're not disoriented or confused, if they can still answer your questions, you may be able to take a full face mask and an NPPV system, either the Trilogy. You can do it with a Servo I. There's several different NPPV systems on the market. You may be able to intervene and not have to intubate the patient. But if the PCO2 is less than 7.25 and you've had some serial ABGs that are pointing toward respiratory failure, you want to intervene as soon as possible. So if you see that downward trend, go ahead and recommend intubation, especially if your pH is less than 7.25. If your patient is apneic, you cannot place them on NPPV. You have to go ahead and intubate them. The patient has to be able to spontaneously breathe in order to be placed on NPPV, which includes BiPAP, okay? So note your normals and when your levels are abnormal for your ventilatory mechanics. If your MIP is less than -20, choose to intubate. If your respiratory rate's less than 8, choose to intubate. If your minute ventilation, which is your respiratory rate times your tidal volume, if that's less than 10, you're going to want to go ahead and intubate that patient. If your vital capacity is less than 10 milliliters per kilogram, or less than twice the tidal volume, go ahead and intubate your patient. If the tidal volume is less than 5 milliliters per kilogram, go ahead and intubate to maintain respiratory status. If your MEP is less than 40, your dead space tidal volume ratio is more than 60%, that's a red flag that says go ahead and intubate. If your shunt is more than 20%, you're going to want to go ahead and intubate. We want to get that shunt to less than 10% if possible. If your RSBI is greater than 106, then you're going to want to intubate and maintain that airway so you can manipulate your blood gas. So when you set the ventilator up, on initiation, the least important part of vent settings that you're going to choose from is going to be your mode. And so don't make a decision based on mode. The MBRC really likes SIMV. It is more comfortable for the patient, and it does require the patient to do some of the work according to what you set your rate on. And it gives them the ability to take those spontaneous rate and tidal volumes in addition to the set rate and tidal volume. The difference between assist control and SIMV is assist control, every breath they take is going to be set at at that set tidal volume. So if you have them on assist control of 450 and they take the 12, or they receive the 12 breaths that you have the ventilator set to deliver, then you're going to have that set minute ventilation. But if they take an extra 6 breaths at their own tidal volume of maybe 333, 385, 352, then they're going to be able to take those spontaneous size tidal volumes, and you're going to have a spontaneous minute ventilation. And then when you add your spontaneous minute ventilation to your set minute ventilation in SIMV, that gives you your total minute ventilation. But if they're in assist control, every breath that they take, whether it's a spontaneous initiated breath or a set vent breath that you have already set, if you've got them set at 12 breaths per minute, then you know that there's 60 seconds in a minute. And if you divide 60 seconds by 12, you're going to get a 5-second ventilatory phase. And then, so every 5 seconds, your ventilator is going to give a set tidal volume breath. And that breath is going to be, if you've got the vent set on 450, every breath that the vent gives is going to be 450. And if your patient assists with an extra rate of maybe 6 breaths a minute, those breaths are also going to be that set tidal volume of 450. So your spontaneous tidal volumes are going to all be 450. And then if they take an extra spontaneous rate of 6 per minute, then you're going to add that spontaneous minute ventilation to your set minute ventilation, and that's going to give you your total minute ventilation for that patient. So assist control, all breaths are at the set tidal volume. In an SIMV, you have the set rate at the set tidal volume, and then the patient can take their spontaneous sized tidal volumes as well, and a spontaneous rate. So SIMV is a great weaning mode, and you can turn the rate down all the way down to 4. And if the patient's RSBI is less than 106, then you can go ahead and begin weaning SBT, spontaneous breathing trials at that point, so you're able to wean the patient easier in SIMV. So the MBRC likes for you to choose that. If you have somebody that has had a surgery or is heavily sedated, or you really need to meticulously manipulate that ABG, then assist control may be more helpful. But mode is least important in the initial phase, in stage 1 of initiating a minute ventilation. You're going to want to choose a rate between 10 and 20, an FiO2 between 30 and 60%. The only time you choose 100% FiO2 is if you've just coded the patient and you've just brought them through an emergent situation and you've been bagging them at 100%. You can set your initial FiO2 at 100% and then titrate down to keep the SpO2 at 92 or more, and keep that PO2 on the ABG that you'll be doing to keep it stable at least 60. So you used a previous FiO2 if they were on a cannula or a mask, or you can use the previous FiO2 if you were coding them at 100%. But typically you're going to set the ventilator between 30 and 60% initially, and then titrate as you need to maintain those oxygenation components of the ABG. Another thing that's going to help you with oxygenation is your PEEP. Therapeutic PEEP starts at 10, so any PEEP less than 10 is a suitable starting setting. If the patient was receiving any PEEP before, you should set the initial PEEP at that CPAP or EPAP level if they were on bi-level. So PEEP is used to maintain that airway and split open the airway and recruit that alveoli, and increase that connection there at the AC membrane so that you can correct oxygenation problems. So if the patient has ARDS, PEEP is your best tool to treat that and to try to correct that refractory hypoxemia. Now you may be asked to increase the PEEP more than once in one CSE. So if you start at 5 or 10 and the PO2 is still too low and the saturation is too low, you're going to bump up in increments of 5 with the adult until you have a stable PO2 or SPO2, and you just need to keep an eye on that cardiac output and blood pressure. If all of a sudden you've given them up to 15 of PEEP or 20 of PEEP and your hemodynamics are still stable, that's fine to use. But if you bump up to 25 and suddenly your blood pressure drops significantly, your cardiac output drops to an unsafe level, then you want to go ahead and back them back to the setting that still allowed them to maintain adequate hemodynamics. So that's using optimal PEEP that helps with the refractory hypoxemia and helps to correct the PO2 and the SPO2, but does not give us a scary, basically, hemodynamic numbers on the monitors or on the Swan-Ganz, because you want to be able to maintain that cardiac output and in order to perfuse the tissues. So remember, mode is least important. Set your rate at 10 to 20, your FiO2 at 30 to 60, or unless you've just had an emergent situation and you want to start at 100% and then titrate to maintain your saturation in PO2. Use your PEEP beginning at 4 to 6, and don't be afraid to increase it in order to treat refractory hypoxemia, especially in your ARDS patients. So we have volume control modes, lock assist control, SIMV, and then if you turn off the rate and they're able to maintain just in pressure support ventilation, something to help them overcome resistance of the tubing and help them maintain adequate FiO2s, then you can adjust the pressure support to help support that. You always want to use pressure support with SIMV mode. That way the patient doesn't have to overcome that resistance, and it's much more comfortable for them to have pressure support in use. Usually around 8 is a good place to set your pressure support, and then just watch your tidal volumes and see how much boost they may need. So volume control, SIMV, is your optimal mode. Volume control, assist control is the second best. Pressure control is to be used when the peak inspiratory pressure becomes 50 or more. And that is to protect from barotrauma, because a lot of times when you get a peak inspiratory pressure beyond 50, you're at really high risk of causing a pneumothorax and really affecting your hemodynamics. So your tidal volume, you're going to set between 6 and 8 milliliters per kilogram of ideal body weight. For a typical patient, if you've got a patient with ARDS, you want to start between 4 and 6. And if you've got a patient with status asthmaticus, you're going to start around 4. So for a male patient, you are going to calculate your predicted body weight at 50 kilograms plus 2.3 times the height minus 60. And for female patients at 45.5 kilograms plus the 2.3 times the height in inches minus 60. That's predicted body weight. You can use predicted body weight or ideal body weight calculation in order to find the adequate tidal volume. So, and then just make sure when they give you several samples of ventilator settings to initiate, then just go through each one. If something is out of range, then just don't use that choice, because if one's wrong, they're all wrong. So know your normal ranges that you can use for setup, and then go ahead and don't use the ones that may have too high tidal volume for that patient's ideal body weight, or just a ridiculous rate or a ridiculous FiO2 that they don't need, because you don't want to use toxic FiO2 levels, which may result in ARDS or other damage to the lungs. Okay, so let's see. Some other things you're going to want to do is make sure that the patient still has that adequate urine output. Make sure they're still excreting 40 cc's per hour if they're an adult. And if not, then make sure that you're not minimizing kidney activity because of positive pressure. You may have to make some ventilator adjustments if it's affecting kidney output as well as cardiac output. So remember, just to review, when you're setting up your ventilator, don't worry as much about mode from the beginning. SI and V will be slightly better than the others if you have that choice and all the other numbers are in range. Make sure your tidal volume is adequate based on the patient's ideal body weight. Start their rate or predicted body weight, whichever calculation you're using. Start their rate between 10 and 20. Use a FiO2 between 30 and 60. 50 is a good average point. Use their previous FiO2 if the patient was already on O2, and if they were just come through an emergent situation, you can use the 100% because you were bagging that 100% when you were resuscitating them, and then manipulate to keep the SpO2 within a healthy range. And PEEP, just begin that at 4 to 6 initially, and you can work up if you are having refractory hypoxemia, and you're looking at your PO2 and your SpO2 on your blood gas and they're not adequate. So you want to use your PEEP to improve that. And remember that use your tidal volume and rate in order to improve your ventilation on your blood gas. So you want to make sure also that you are watching their compliance. If you have an increased dynamic compliance, and we find that by taking the exhaled tidal volume and dividing it by the PIP minus the PEEP, then you know that's giving you an increased airway resistance. So you would suction the patient, correct any a blockage in the tubing or in the ET tube, give a bronchodilator if their increased airway resistance is because of bronchospasm. And then if you check the static compliance, and you do that by calculating the exhaled tidal volume divided by the plateau pressure minus the PEEP. And if that is out of range, then you know that any decrease in compliance is going to cause a stiffening of the lungs, and your static compliance is what reflects that. So remember, stat is your plateau pressure. Stat and plat is what tells you that you're having compliance issues. So you don't want your plateau pressure to be any out of range from the normal of 10 to 20 centimeters of water. If your plateau pressure approaches more than 30, your patient is probably going to need popped over into pressure control because their compliance is decreasing. poor compliance. We see that a lot in ARDS and in some neuromuscular patients like ALS. And so you want to keep an eye on that, intervene as soon as possible, and call attention to that from your team. So you can also tell when you're bagging a patient. If it's super hard to bag the patient, then you're losing compliance. So you don't want to cause pneumothorax on top of that by over-ventilating the patient and using high pressures, or high volumes. So if you start seeing your peak inspiratory pressure creep towards 50, remember that's when the NBRC wants you to change over to pressure control mode. You do have to watch your tidal volumes and make sure they're adequate as you're using pressure control, because tidal volumes can vary. So the thing about which type mode you're using, if you're in volume control, your peak pressures can vary, so you have to watch those. And if they edge towards 50, then you're going to want to switch over to pressure control. But when you switch to pressure control, your tidal volumes vary, so you're going to have to keep an eye on those. So it's kind of which one do you want to control, and which one do you feel comfortable allowing it to vary some, because you can't really control a PIP and tidal volumes specifically. It's according to which mode you're in and which one you're able to truly control. So keep an eye on those. Make sure that if you get a high pressure alarm, then you know that you've either got secretions in the airway, maybe the nurse assistants have turned the patient and they're laying on their tubing or their circuit. You may have a kink in the ET tube, excess water in the vent circuit. You may just have some severe bronchospasm, and you may have to give a bronchodilator in order to increase or correct that increased airway resistance. And then if you've got a low pressure alarm, you know you've got a leak of some kind. It's too easy for the ventilator to deliver the breath, and it's giving you an alarm saying, hey, you've got to correct this. For some reason, I'm able to deliver this volume super easy. It's not taking a lot of pressure. You better check it and see what's going on. And a lot of times you could have a leak around the ET tube, could be making it easier for the vent to deliver the volume, but it's not truly delivering it because it's not really inflating those alveoli. It's coming right back out around where that leak is. Sometimes if you're not using a temperature probe in the little door that is in the vent circuit there at the inspiratory limb near the Y, then that little door can pop open sometimes and you can have a leak there. So you want to check anywhere in the vent circuit around the ET tube that can cause a leak. And if your ET tube actually has a tear in the cuff, then you're going to lose cuff pressure, and it's according to how bad that tear is. You may have to replace the ET tube due to damage to the cuff and inability to keep that cuff inflated. Remember that in order to determine the best cuff pressure, then you're going to want to use minimal leak technique, where you inflate the cuff until you don't hear any air moving around the cuff, and then just deflate it enough till you hear a tiny leak, and that tells you that the cuff is anchored in place, but you're not putting too much pressure on that mucosa and the capillaries of the trachea, so you're not likely to cause tracheomalacia with that ET tube cuff pressure. So if you have the patient on the ventilator and it looks like it's going to be a long-term mechanical ventilation use, then after about 2 weeks, when you start nearing the 2-week mark, if you're unable to wean them, they're going to go ahead and move toward a trach. And you're going to do a percutaneous trach at the bedside, or they may be taken to surgery to receive that tracheostomy. Okay? So just be aware of what causes the different alarms. when you should change the mode, when you should initiate weaning, when you should not wean and just maintain the patient at either in pressure support or in SIMV at a lower rate. Let them do some of the work. If you have a patient that you have in a weaning trial and for the first 4 hours everything remains stable, but then on hour 5 they begin to have an increase in heart rate, blood pressure, respiratory rate, they start getting in distress, then you're going to want to stop that weaning attempt, and you're going to want to go ahead and put them back on a set rate and tidal volume, and then the next time you can try again and see how it goes tomorrow. But don't leave your patient in distress and just make them keep overworking. Go ahead and give them a break at that point, and you can build up over time and hopefully get them weaned successfully before they have to be trached, or sometimes they have to be trached and then the weaning has to continue after that. So okay, so well, that ends this session. If you would like more in-depth on any other information, any other subject, let me know and we can arrange another study guide video or recording and talk you through these different subjects and have you ready to take that CSE. I do have some CSEs that I've made up myself that are very close to what you're going to be looking at on boards. If you would like some samples recorded for you to listen to, just let me know and we can arrange a new recording. But I think we've covered quite a bit of information that will help you be prepared for boards for this recording. So let me know if you have any questions. I appreciate you, Sloan, and I hope you're going to have lots of success for us to celebrate. I get as excited just about as the person taking boards when they're able to get over that hurdle. I know what it means, and I've been through this myself, and it's a great feeling to walk away knowing you accomplished that, and we want you to be able to take that, have that feeling on your next attempt. So like I said, I'm sorry for the delay from the hurricane, and I'm glad we got to do this. And if you want more recordings, just let me know. Or if you want to have a one-on-one tutoring call, we can go over specific questions. Just email them to me, and I'll be glad to explain the answers to you. Let me know how I can help, okay? All right, you have a great day.